I'll tell about some clinical defects of CNS. First is the neural tube defect. The primary cause of neural tube defect is not known. However, many predisposing factors like hyperthermia, drugs like anticonvulsant, antifolate, malnutrition, folic acid deficiency, radiation exposure, and genetic factors like mutation in the folate-dependent pathways have been attributed to its cause. So, hyperthermia, drugs, malnutrition, radiation exposure, and different genetic factors. Now, first is the spina bifida occulta. So, spina bifida occulta, this is usually a self-limiting defect of the vertebral body caused by inability of the neural tube to separate from the overlying ectoderm. Most common presentation is being dermal lesion like patches of hair, lipoma, pigmented macules, hemangioma, or a dermal sinus in the middle of the lower back. So this is the more features of the spina bifida occulta. Self-limiting defect and most common presentation is being dermal lesions. Then the meningocele. Meningocele, this is caused by herniation of the meninges. This is caused by herniation of the meninges through a defect in the posterior vertebral arch. In female, there may be associated genital tract abnormalities like rectovaginal fistula and the vaginal septa. Then the myelomeningocele. Myelomeningocele means this is the most severe form of the neural tube defect characterized by herniation of the meninges along with the spinal cord. The most common site of location is lumbosacral region. The clinical presentation depends on the site of the location. Lower sacral lesions cause bladder and the bowel incontinence with perineal anesthesia. Mid-lumbar lesions causes facet paralysis of the lower limbs, constant urinary dribbling, laxed anal sphincter, and a higher incidence of the lower limb deformities like club feet and subluxation of the hip joint. And hydrocephalus can be seen in 80% cases and is commonly associated with type 2 CRE defect. And treatment comprises of early surgical repair within 3 days of the defect to prevent the infection. This is followed by shunt placement for hydrocephalus. Broad spectrum antibiotic from birth till closure is indicated. The most common postoperative complication is wound dehiscence, which can be followed by CSF leak. If a shunt is not placed, the baby is at a high risk of fetal contamination of the wound, and in case of CSF leak, meningitis is unavoidable. In these cases, CSF studies should be done with biochemical parameters and culture. So this is about myelomeningocele.